Welcome to The Whole Pineapple. I'm Ruby Boris.
And I'm Ann Judge. The Whole Pineapple is a podcast about wellness focused around fertility. We'll talk with experts on a wide range of topics, including nutrition, stress relief, sleep, mental health, etc.
And we'll dig into the issues that can cause fertility challenges, like PCOS, or early menopause, or cancer treatment.
So if you're curious about your fertility, whether you're ready to start a family,
or you're preserving your options for the future, let's dig in. Hey there, Pineapple family. This is Ruby Boris.
And Ann Judge.
And we are so excited today because we are going to be talking about sexual health and lifestyle. We have a really wonderful guest here. Ioan Hanes is a medical doctor who lives in and works in Brussels, Belgium.
Ooh, it's our first international episode, which we are very excited about.
Fancy we are, yes.
The pineapple has gone global, so...
He's a clinical practitioner in lifestyle medicine and head of the obesity department of the military hospital Minufit, Brussels. Fingers crossed I said that right. Where he works as a certified medical nutritionist. He's also a clinical sexologist. He has completed several different lifestyle medicine related courses in the US and Belgium. He has a strong interest in the field of sexual health and lifestyle medicine. He's the founder and coordinator of the European Lifestyle Medicine Certificate and co-coordinator of the first European Lifestyle Medicine book. He is the founder and president of the Belgian Lifestyle Medicine Organization. Oh, and he's a multicultural practitioner, which is demonstrated in not one, not two, but 5 languages that he speaks fluently. So English, French, Romanian, Hungarian, and Dutch. And do you happen to speak Dutch?
No.
Okay.
Is no a word in Dutch? I know no is a word in a lot of languages, so that's probably the only one. But
I speak some Spanish, so I don't think we'll get very far with that. And as fun as it would be to do this interview in Dutch, I don't think we'd get very far with that. So welcome to the podcast. Thank you so much for being here.
Thank you for inviting me, and good morning to you from Brussels, from a very, very warm Brussels today.
Well, good afternoon, early evening to you.
Yeah, I guess we'll just jump right in because I know one of the things that I hadn't really heard before until your bio was the term for being a clinical sexologist. So what does that mean? What is a clinical sexologist?
If I would like to make it very short, it's someone who works mostly in clinics to treat sexual related health problems. Mm-hmm. So that would be the definition. But in real life, I'm just integrating in my practice most of the sexual health related medical problems and mostly with men. So part of my work is with soldiers, and then I still have a private clinic. But the idea is that a clinical sexologist list here in Belgium, it's a certified one. Until recently, everybody could call himself a sexologist. Since a few years, you have to be a registered sexologist in Belgium to be able to practice that.
What's the certification process like?
Myself, I did all what was possible. So I did a master's degree a few years ago in family studies and sexuality. I came from something else to do that course, and then I fell in love with sexuality studies. To be a certified clinical sexologist, you need to do a 3-year postgraduate academic training, and then you can call yourself a clinical sexologist.
And that's really a lot. You know, it's not just like you take a little 5-unit online course and then you get a certificate. I mean, that's a pretty significant investment. That shows that it's a really meaningful designation to have.
3 years here in the U.S., that's a residency for all of us U.S. Healthcare people. That's the length of most medical residencies.
It's not a full time. It was usually in the evenings and some trainings, what you did. And then I still completed that in other weekends when I was free with another approach in sexuality, the sexoanalysis, which actually is coming from a place closer to you from Canada. So it's Claude Crépeau who founded this sexoanalysis. It's built around 3 main pillars. So sexual fantasies, masturbation, and then sexuality shared with somebody else. So very, very shortly, that it's a bit about, but it's a lot of psychologic part indeed. So.
And do you primarily work with like heterosexual couples, or are there LGBTQIA facets in this as well?
I work with whoever contacts me. So even if there are specificities, from my experience, but most of the medical problems, I would say, if I want to stay in the clinical field, are the sexual dysfunctions. So erectile dysfunction in males. So this is what experienced mostly, and or premature ejaculation and low libido. And the low libido I find also in female patients, and then dyspareunia or pain during sexual intercourse. So those are the most frequent what I meet in my practice. I would say that what is the most prevalent is the low libido. So people love each other, but they don't desire anymore each other. So that is one of the biggest challenge today.
And I think those things you mentioned are probably definitely the big ones that we refer out to as well when we're dealing with couples in clinics that are wanting to improve on their sexual relationship, either in terms of enhancing their fertility or as kind of a byproduct. Because sometimes we have people that are coming into the clinic who don't have sex and they want to have a child together, and we're doing fertility treatment, but then maybe they also realize that they would also like to be improving that aspect. And that is a key part. There are people who are perfectly happy in a relationship without having that component. But if you have a situation where, as you said, they aren't desiring and they want to be desiring, that's where there definitely are some things that we can do that can help. And we're not experts. This is why we refer out to other people. And we're really excited to get to hear your approach too.
You are probably more expert in the fertility part. They are actually, it's just, I would say the last 6 months, 1 year that fertility clinics starts to be interested about sexual health, but from perspective of lifestyle interventions. So this is where, when I was first time, some fertility clinic contacted me, I was more a bit, what should I do there? And then, at least in Belgium, they said that almost half of the totally healthy couples, they cannot have a child and they don't know why. So this is why they are more curious about the lifestyle factors which can influence that.
Yeah, and with that unexplained infertility, I think we see the same thing, is there's this desire to just do whatever you possibly can to help yourself out, and lifestyle does play a big role in that, because that is something that our patients can feel like they can control. They feel like they're doing something good for their body, but also potentially their future pregnancy.
Now, were you already an expert on lifestyle medicine and then you developed this interest in sexual health, or were you working primarily in the sexual health field and then you started expanding into lifestyle medicine? What were you doing first?
Originally, I'm from a very historical, good for tourist region, so Transylvania, Romania. And then I came almost 20 years ago in Belgium to study nutrition. And I love nutrition. I really thought that the way how we are eating says a lot about who we are. And then there I realized that actually has a lot of emotional part, the way how we are eating and all it's related about nutrition, anorexia, bulimia, just to mention a few. And then I wanted to do a bit more than that master degree that I did at that time. And then I found some courses in another master degree, which I just mentioned at the beginning, family studies and sexuality. And then I realized that people, they like, all the people, almost all of them, they like not just to eat, but also to have sex.
Yeah, food and sex are some pretty key things in life. So
I think they hit the top of the list, I'm pretty sure.
Yeah.
Yeah, exactly. Then with this, I was contradicted with the sexoanalysis concept, which they said that sometimes you find people who just don't like sex, and like some people who don't like wine or cheese, it's also the same. But I didn't know at that time. So during that course, I just realized how much we can know about ourselves, actually, because that was one of the requirements when I started the 3 years postgraduate studies. We are invited also to know more about our sexuality, but how much you can help actually people. There are people who are suffering because they cannot talk about something that sometimes is not even clear for themselves. And this is expressed sometimes in their dreams. It's expressed in some fantasies that they are looking for porn, through porn and so on. So the point is, as usually like health professionals who we want to help people, is just another way to help more.
Mm-hmm. It's that holistic approach to the whole person approach.
Exactly, holistic. But there you arrive to another challenge, is how you talk about sexuality, sex. This is still a challenge, not only for the patient, but it's also for the health professional.
Absolutely.
Well, it's interesting that you, speak so many languages. You probably work with people from many different cultures, which is challenging because there are so many cultural issues that play into how we are comfortable talking about sex. Some people are brought up with it being something that they do kind of talk freely about versus in other cultures, it's really not even discussed. Have you had to learn different approaches to try and talk about these things since they can be hard for some people?
Unfortunately, in my studies, not much.
Okay.
But I was lucky that I'm coming from a multicultural, whatever that means today, background. So I had two mother tongues, if I can say this. And then living in Brussels, it's impossible to not be open to other cultures. And then I tried to have in all my consultations, even if they are not necessarily sexuality related, I always ask, look, is something which bothers you from sexual points? So in the case of men, I'm saying, look, some erection problems or libido problems, and in women, some pain during sexual intercourse or libido. And I must say that there are some generation differences in how people reply to this. But I would say if I can do a general percentage, 1 person in 4, they are open to talk about something which is sex related.
I think a lot of people are open if you ask. It's just a lot of people may not bring it up.
Maybe we're just really pushy, Anne. I think we're just really pushy in our clinic. We're like, no, we're going to talk about this because we talk about sex all day long. So,
oh, well, I'm not. Well, I admire you doing this because I'm not sure that I would like to talk the whole day about sex because sometimes you have stories which, it's a bit too much.
So you see it more in generational so people that are older are maybe more hesitant, or what are the generational challenges you see?
I'm talking about Belgium. Unfortunately, I don't have many LGBTQIA patients, so this is why I don't want to generalize for all. But usually women around 50, 55, they are just the children, they went away, they would like to really enjoy life. So it's a moment if they see that their husband is not really more open to rediscover life, they divorce with all what that involves. I was very surprised that very young women are more open to talk with a man, with me, about sexual issues. For the rest, I think that all what was related about the blue pill and something made men to be very open at any age to talk about sexuality. So that I think sometimes even surprised me that someone even at 80 years old, it's still important. So wants to talk about erectile dysfunction, for example.
And I suppose that's true. That's a good point to bring up, the fact that people have heard enough in the media that there's going to be a treatment for erectile dysfunction makes them a lot more likely to disclose versus, I know when you're talking about low libido issues for female, I mean, there's a lot of buzz, but there's not a clear path. And I think that does make people maybe a little less likely to even bring it up because they feel like, well, what do you have to offer me if I disclose that I'm having issues?
I mean, low libido, if I would have a solution, I would be probably very famous.
Yeah, very rich.
And rich as well. But what I try always when people are coming with sexual challenges, issues to me, it's like, please degenitalize the sexuality. Sexuality, it's much more than penetrations. And if you understand this, it's easier to deal with the desire. So then you are, I mean, it can be very erotic to go out, to just, for example, to play like a first date or just a touch. And here are coming the way how we relax. We don't know anymore. I mean, please look around. If you look around, the perfect body, even teenagers at a very early age, their first contact with sexuality is through porn and so on. So this huge pressure of what means today to be sexually active, it's impossible to work on everybody. The moment when you start again to relax and to give time to yourself, or to be kind with yourself, I think that it incorporates everything. In that moment, you are on the good way to discover again what means sexuality for you.
I think that's great. And especially in our practice, because many people who are coming to see us have that goal of pregnancy, it's very hard to not be focused on penetrative intercourse, ejaculation, pregnancy. It's all about like, what's my fastest path to pregnancy, which is sort of the backwards approach of really, as you said, even starting just working on yourself and thinking about what are the things that can make you feel in that place again.
There's an agenda that kind of hijacks the whole experience.
The most important factor is the psychological factor in infertility. And I just can imagine how stressful could be this, that all the time, just, okay, when I got pregnant, when is the best moment for fertility?
Well, it's huge because what we see in research when people drop out of treatment and stop trying, it primarily is because of stress and what they call treatment burden and just the emotional aspect. When you look in countries that have coverage for treatment, because in the US it could be so expensive, it's often not covered by insurance. But even in countries that have many cycles covered, or in states in the US that do mandate coverage, you still see a lot of people stop treatment early, even when they're what's considered a good prognosis, meaning their care team feels like they just haven't gotten lucky. Even the best odds treatment still has a very good chance of not working in that first cycle. And it's common to have to do treatment multiple cycles, and that can be really, really hard for people emotionally. So you're right. I think this is all part of that same thing, where we need to be aware of that psychological factor.
Yeah. And do you happen to know, because I don't off the top of my head, how many couples that go through infertility treatment, actually their relationship ends because of the stress of going through?
I don't know it off the top of my head. It's interesting though, because I feel like it's one of the, I think it's like any event when you look at families that have a special needs child. I mean, anything that's a giant strain on the relationship, there's certainly a percentage but there's also a percentage that come out stronger. I mean, I think there's a lot of research on that too. So I think
I don't want to like scare our listeners or anything like that.
It's one of those things where it is a shock. And for many people, because it tends to hit you in this prime of your life stage, it's often the first big shock. It often happens before the death of a parent. It just depends on when it happens in your life. For many people, it's the first thing that hasn't gone to plan.
Yeah, first big stressor in a marriage.
Everything else you've done has been a little bit more under your control. And certainly, obviously for lots of people, other unexplained things have happened. But in terms of a challenge that you're both facing together that you don't have control over, that is what's so challenging, because you can do everything right. You can follow everything exactly, and it still may not give you the outcome that you're looking for. And that can be really hard because couples often process that in very different ways.
For sure.
And that's why we don't want to be, I know we're talking a lot about kind of gender stereotypes and roles, and we know that not everybody processes things in that way, especially as we're talking about sexual health. But I do think it's still worthwhile to talk about, because I think you can see a lot of common patterns and themes, and even if they don't all apply to your particular relationship.
I agree, because half of the solution is if you know how good to listen to your patient. Then this is why, for example, I also train myself in a motivation interviewing, which really teach you how to empathically, non-judgmentally to listen to your patient.
I've done some of that motivational interviewing kind of training, and it is hard, especially for somebody with ADHD who gets excited about a conversation, who is prone to interrupting people, to sit and just listen. Because it is so important in what we do to be able to help a patient, we actually need to really know what's going on and to really listen to them.
You have a lot of health professionals who are very judgmental with somebody just different than the health professional. I think, and I strongly believe this, that if you are in the health sector, you should be trained. And if you cannot control your judgmental part, it's not your place in the health sector. So, but maybe it's a bit radical how I'm thinking, but I really believe that this is very important, because we all, and I don't know how it's in US, but here in Europe, I think really that everybody deserves to get the right advice. And there was some studies which actually was performed in US when they asked health professionals if the patient would be interested to have an advice according to his sexuality. And they were not so open, no. And then they asked the patient, and actually almost 80% or something higher, yes, they want to have advices according to their sexuality.
Now, it is a challenge with our different healthcare systems, because one of the main things in the U.S. is there's often not coverage. How does it work for you? Is when you're seeing patients, is it just part of universal healthcare? Are patients having to pay on their own to see you? How are your services integrated within the bigger system?
I'm a bit lucky because I'm a medical doctor, so part of my consultation are always reimbursed. And then you can add certain supplements to your base reimbursed consultation. Here in Belgium today, you can be a clinical sexologist or a sex therapist today only if you're a medical doctor background or health professional or psychologist. We are a bit lucky with the system that which, if not, you are paying from your own pocket the whole consultation, which starts around 60, 70 euro per consultation. So that now with the parity of dollar, it's the same.
That's pretty comparable, I would say.
Yeah, that's not too bad, honestly. So
lately, the last years, sexual health is brought more and more in the general consultation. This is what I see. So I hope that could be more and more covered. Because as you know, probably many people think that talking about sexual health is just some eccentric things which people just get bored and say that's not good in bed. And okay, let's talk about this. But sometimes like erectile dysfunction can be also an early sign of a more serious, like a cardiovascular problem.
definitely.
Yeah, absolutely.
Even COVID, we succeeded to make it somewhere in a kind of chronic disease. So today, the quality of life of our patient is so important. And sexual well-being, because I saw that there are people who are using this concept as well. Sexual well-being is something which should be part of this. And I think this type of discussion, what we have, and maybe someone there in US will just listen in the car, what we are saying here, said, oh yes, that is a good idea. Let's make something in this.
I like that term of sexual well-being. It is a much broader concept than just the actual act of sex. Your sexuality is bigger and it impacts so many areas of your life. So I like that a lot.
Well, and it definitely brings up that lifestyle medicine piece, right? So like the whole person approach where we're addressing nutrition and movement, physical activity and stress
And sleep.
and sleep and all of those things. So yeah, I think that's part of it. And you're totally right that everything's connected, right? So if something's not working sexually, there's probably other things going on as well that we need to discuss.
And obviously everything's individualized, but in general, what would it usually be like when you see a patient? How many times do you see them? How often are you consulting? I assume you're trying to be somewhat focused. It's not like you see people for years of like a psychoanalyst where you're having to talk to them weekly for 5 years. What's your usual plan for trying to help someone?
If we talk about chronic disease, there we usually in 2-3 consultation, we try to find a solution for the sexual dysfunction because, okay, it's just a part of why the patient is coming. So unfortunately, often it's very medicated. So medication plays a role. Not everybody has the patience to go deep at the roots of the problems.
That's very similar here.
Give me the pill.
Yeah.
Exactly, the pill or the gel or whatever it is, okay. But when it's about typical sexuality-related consultation, there, first of all, we have to learn together to name what is happening. And that could take some time. So you can have 1, 2, 3 consultations until someone can say, yes, I did something with myself. So I said, tell me what, this is why you came to a sexologist to be able to name it. So that could take more weeks. Because, and then, as I mentioned, I explore a bit these 3 directions. So the fantasies, so the sexual fantasies, it's sometimes very challenging to define for someone coming from a culture or an education which was not allowing this.
So are you giving people homework? Are you telling people before we meet again, I want you to like work on these? Like, how do you?
Yeah, exactly. And I would say that here the homework could sometimes to watch some porn. So that helps to see which type of porn they like. Or, for example, I had once a couple who came for a low libido issue and then was very trendy at the time, 50 Shades of Grey. So I just recommend them to go together to watch the movie. And the woman was very, very excited. Oh, I love this. And then the man said, oh, I found it very disgusting, this movie. So yeah, homework is part of this. And then you have what we call, depends if it's a man or a woman, the king or the queen role. So what would you do sexually if you would be a queen and you have the total power? So fantasies are really important to be explored. And sometimes people, they need time to learn what really gives them pleasure.
Are you often doing sessions when people are in a relationship? Are you usually talking to both together or do you typically see people by themselves?
I prefer to see people alone, because when they're coming in coupled, it's a whole movie which is going on. So you can see people are coming very lovely couple. Oh, we love each other, and when you see separate them, they just hate each other, but they don't dare.
Well, I imagine, like, even if you've been married for a decade and, you feel like you have really good communication, when it comes to sex, there might be some things that they still don't feel comfortable sharing with their partner, or they haven't gotten to the place where they're comfortable sharing with their partner, either what they are wanting, or maybe they don't want to hurt their partner's feelings or something like that. Do you find that that comes up when they're together, that they're not as open together?
I mean, we arrived to the communication issue, but maybe before this is, at least in the sexoanalysis concept, is that they divide people who like sex and people who are just don't like. What means that someone likes sex, not that we need sex every day, is that it's open. We grow up as we develop in other things. We can develop also our interest, our curiosity, our need for different experiences, which can be alone, in couple, or in group, whatever brings to pleasure. But if someone is coming together, someone who likes sex with someone who just doesn't like sex, then it's a big problem. I would not say that they will divorce or we separate, because people stay together for many, many reasons. But from sexual point of view, it's very challenging to find. And I just mentioned you this couple. The woman, she really wanted to explore her sexuality, even if she was close to 40. But her man, no, he was not interested. No, he was just very good. So he came in consultation because she insisted, and he loved her really. But he was not interested to change. And if someone is not interested to change or to explore, then you just lose your time with such a patient. And the patient as well, if is not interested to change. So just don't come.
If someone doesn't have a motivation to make any changes, you are kind of at a bit of an impasse. And it's interesting to me because I love reading advice columns, and I like to read some of these like sexual advice, health columns. Half the times I feel like they're kind of using like a get out of jail free card to just say, well, I guess you should open the relationship. And it's like, but there are a lot of people that maybe they don't want that. But it's like, I feel like we used to talk a lot more about other strategies. And I feel like now, with an understanding that open relationships are more common, I feel like a lot of people just offer that up as the first alternative. Oh, it sounds like there's a mismatch, time to open the relationship. And there is a middle ground if people want to have monogamy, but can still try and explore other ways, even if you have a bit of a mismatch. I wish we talked a little bit more about alternatives between going outside of the relationship.
Definitely having sexual fantasies, it's not a monogamous attitude, but you are still virtual. Whatever virtual will mean in future, but it's not an easy question. And indeed, many people today, open relationship could be assumed or not. And I think here it's because we're talking one moment about generation. I think young generation, they are more fluid, more open. I always ask why you are together. If you stay just for sex, probably in one moment, just two of you will not be enough, because only sex, that in my opinion, doesn't build a relationship. It's an important part, but you need to have something else. And if you have more than, not just only this, then you can build a relationship. And I always said, sometimes, okay, you can open your relationship, you can try, but be aware that this has consequences. We talked about sexual fantasies. Sometimes it's very nice and you can enjoy until it's virtual. But when you try to make it real, most of the time it's a disappointment. So if you both assume that, okay, let's try something, it's okay. But one approach, what I like, it's the sensate focus. Sensate focus, you have different version of it, but what I recommend is the 6 weeks. So in a couple, which face desire challenges, I would say. 1 week, it's one partner, so that can be applied to, doesn't matter which gender identity you have. So one is who is preparing everything for a massage. Another one is the receiver who will enjoy all these preparation, what is done, and you book it. So it's not like we will see, no, you have to book it, you prepare everything, and then you discover through massage the body of her. And of course, we say no sex, no touch genitals. Of course, if they will happen, that we are happy, but actually it's to refill again the body of the another one. So that you do 1 week Another one, it's another one who is switch. So first, it's just, as I said, full massage without genitals. The second part, it's you can touch genitals, but you don't do more than touching. The last part, it's when you can enjoy if it's coming something more than massage. And this preparation, this found eroticism, the small details that you really invest time, because we said that time is always a challenge. And you do this because you want. Because in the moment when you don't want to do something for your couple, you don't want to do something to spice, then there is not much to do, because we talk about motivation. If you're not motivated anymore, if you don't have nothing else in common, then unfortunately separation is a solution.
I like having a schedule. Ruby and I are list people. So I like the idea that you'd have your little 6-week plan. And
I do well with a plan, like when it comes to fitness or whatever.
Mm-hmm. And so when you're doing this, you're kind of talking about these things, but you're also talking about lifestyle approaches. What are some of the key things that you bring up from the lifestyle medicine aspect as it relates to sexuality?
Of course, someone who has some extra kilos and doesn't care about these hormonally will lower the libido. It's not only because you don't find yourself attractive sometimes, but it's also, as I mentioned, libido, extra weight problem. Then sleep. If we don't sleep enough, it's a bit difficult to be in a mood for something. Or if we don't have a quality sleep, so the sleep apnea, snoring, it's often a cause of erectile dysfunction. I don't have to mention, I think, more about smoking, tobacco. It's a known cause for sexual dysfunctions.
And bad for sperm, too.
Yeah. Stress. Now you have a topic with illegal or street drugs. I will not say alcohol. Alcohol until a moment can help put in the mood, but on chronic consumption, it doesn't help your sexual life. Now, street illegal drugs, it's very trendy, especially young generation, the chemsex, probably you hear about, so having sexual activity under influence of drugs. It's increasing libido, it's really making stronger orgasm and so on. But on the long term, it's a cause of sexual dysfunctions. And what is long term, then I let everyone to decide when it's really facing this.
Well, it seems a little bit like that's a little bit like with pornography too, like you're getting some unrealistic expectations, like especially if you're thinking about younger people and some of their sort of earlier sexual interactions or under altered substances, that's probably going to make it seem strange when you start having sex without that. You know, if you kind of expect a certain stimulation, that it's
certain sizes, certain activities. But you know that actually 20% of the males between 20 and 30 years are experiencing sexual dysfunction. And it's the cause, it's excessive pornography. So it's huge. It's very, very huge. Now, as I mentioned, pornography can help to identify your sexual fantasies sometimes. And this is why the industry of pornography, you have some scenarios. And that was a bit targeting women or that category, which before we didn't imagine to watch this. But indeed, as you said, pornography, it's not the real life sexuality.
That's a tough stat. Like, do you have any other numbers about kind of how common just sexual dysfunction is overall in different age categories? I'm sure it's kind of a hard thing to study, but...
Yes, especially because, as you know, female sexuality until, 50 years ago, was considered like a hysterical. I mean, a woman who wanted to have an orgasm was considered hysterical. So this is why, unfortunately, studies about woman sexuality, they are very recent, not a lot. So it's still a lot of space, and I think it's more complex than male sexuality. Now, about erectile sexual dysfunction in men, when we talk about erectile dysfunction, it's by percentage. So as mentioned, between 20, 30 or 20%, 30, 40, 30%, and so on. Of course, those between 20 and 40, I would say that they are excessive. It's considered that excessive pornography is the cause, or some stress when someone between 30, 40. And above 40 years old, they are there. We have to look a bit if they are not something organic. But this is why if you meet a man and he's telling you, oh, I never had erection problems, it's a liar. so that it's happening always in one moment of the life. We consider it dysfunction if it's regularly more than 6 months.
We haven't done sexual scripts yet.
Yes. Sexual script, it's a concept introduced by Simone Gagnon. It's about how you, like a health professional or a patient or a person, what is the relation with sexuality? And here, your culture, your education, they are really playing an important role. I always give this as an example, a study which was performed in Sweden with Iranian immigrants. So they arrive in Sweden, and then they've been interviewed what they think about classical sexual health related topics like pregnancy before marriage, LGBTQ community, divorce, orgasm, whatever it was. And then after 10 years, they've been invited to reply to the same questions.
Oh, that's interesting.
They've been, of course, influenced by 10 years living in a country like Sweden. So for most of them, their approach changed compared with 10 years ago. But those who replied and they had a change image about sexual health, they replied in Swedish, not in their native language.
Oh,
so even after 10 years, you could not make it in your own language because that is still very deep roots in the culture what you had where you are coming from.
So there's like a language factor too. Interesting. Okay.
I mean, because we talk about many languages, actually, sexual well-being, let's use this because unlike this term.
I do.
I do too. It's really good.
So it's a language. It's a language which to know the grammar, to know the words, to develop it, to read it, to make it richer.
Well, and in any language acquisition, we talk about critical windows, right? That if you're not exposed to a language before a certain age, you'll learn it, but you'll never have the complete inflections. You won't necessarily hear the sounds quite the same way. So I'm curious if there's some sort of window in terms of when your beliefs about sexuality also kind of firm up.
When do you develop your sexual language?
Yeah, like is it harder if say you come to a new country at after age 25 as opposed to when you're 10 years old, if that makes you more open to new experiences and beliefs?
I think you like and to challenge cultural thing because as you know, in some countries, because you said, and I wish that you became global, but in many countries, sexual health education at an early age, it's really something very, very controversial.
Oh, US is very, yes, that's a whole thing right now. I think it's because I have two kids that are pre and teen, and I have a 11 and a 13-year-old. And so they're just having their health classes now in middle school. And so it's kind of their early exposure, and they're still at that age where they like to talk to me about things. So I have this little window right now into what is education. And we're in the Pacific Northwest, which is a pretty liberal bubble in terms of what they get. But no, it's definitely an issue right now, too, in terms of there's a perception that parents should be the only source of this information. It's like a lot of people don't want schools to be giving any sort of information to their children about even basic biology, let alone sexual health. So there's a wide range of experiences in the US in terms of what children are given information on.
I respect people's beliefs and how they've been educated or whatever formed them like a person. But sometimes it's very comfortable to stay with what you learn for. It's very easy to get built because you are afraid. Things what we don't know, it scares us. It's a human reaction. But what is important, and this is what maybe is the message what we have to make it or to address is to pass to parents who they are afraid to let their children to get an education about something which is very normal. It's that sexual health education, it's about the safety of your child. It's not about promoting something which you could maybe not agree today. It's about mental and body hygiene. And just because we talk about the LGBTQIA community, we know today the concept of minority stress. So the fact that you are not able to talk first, because first of something that is going on with you, and then putting words on this is the first step. And then when your own bubble doesn't accept you, that really gives a lot of trauma in the life of someone. And this is what I would ask parents. Do you really want that your own child is really suffering? This is what it's about. It really makes me angry when I see this.
Well, especially knowing that in this current age, I mean, I feel like if you don't give education, you do have the internet, you do have pornography. People are going to just find information and they're going to probably get much worse information than what they would be getting in a curriculum.
Exactly. So pornography, whatever you do, the child at school, whatever you go, I mean, the tragedies, I mean, which is happening, I mean, just give an example, I mean, with pedophilia, for example, it's happening most of the time in the family environment. It's not something outside is doing it. So this is why an informed person, an informed child, and of course we can talk now on which way we can educate, which type of information, and specialists recommend to be very specific what the child is asking, like an answer. So if it's asking about how the baby is coming, you will not talk 2 hours about the whole history of sexuality. So the form can be discussed, but you are protecting your child when you are giving information which helps for the healthy development, because the child will grow up, will choose in one moment someone healthy mentally and physically will be able to choose them. So you just avoid some bad experiences and sometimes tragedies, because you know that in LGBTQIA community, unfortunately, the suicide is still very high, and this should not be the case in 2022.
So like age appropriate, specific conversations.
Exactly.
What did we say in our previous episode, Anne? Like you leaving like
about planting the seeds.
Planting the seeds.
You're kind of from an early age, you and like you said, exactly, you answer the question that's asked, because sometimes you think that someone's asking a big, large, loaded question, and really they just wanted to know this little detail about one little part, and you don't have to overwhelm somebody. You kind of like open up that conversation and encourage it to be an ongoing conversation.
And to trust the intelligence of your child. You suppose that each parent would like to have intelligent child. And
that's right.
Yes. And depending on their age, like my kids are at the stage where they're very literal. So like I am using very specific, usually it's like 1 or 2 word answers, but like, what is this? Well, that's your penis. Like that, like it's very specific and very literal. So there's no need to go into these long, like philosophical discussions with them, because they're asking pretty direct, literal questions. I want to talk a little bit more about your experience with military and sexuality. How is that different between other patients? And have you noticed there's any factors that play into their sexual well-being more than lay people?
It's not a top secret thing, because actually one published, US was steps, because here in Europe, unfortunately, we live some war situation. But actually, it was in US which published. It was some studies done in the military, and 1 in 4 soldiers experienced sexual dysfunctions. The cause can be very different. Like, most of the time it's trauma, but not only. I didn't find a paper about at level of Europe or Belgium, but from my own experience, I can say that statistically fits the US statistics. Most of the patients which I see, they are male, so it's about erectile dysfunction. And then it's very specific for role plays, so that it's probably not something very surprising. In military, we have a lot of power roles, so it's something that was also in US. So it's part of with who you feel comfortable, then some domination issues.
Well, it's interesting for us in the fertility realm, because that's been a big push legislatively to have infertility coverage specific for veterans. Because again, we wish there was nationwide coverage, but there's not. And there was a bill that finally passed and right now does authorize coverage for veterans, but it's only good through September of this year. It has to keep getting renewed. So we're still trying to get like a permanent coverage for IVF, because as you said, 1 in 4, and sometimes it's directly related to injury from military service. Sometimes it is more psychological trauma, PTSD, and it's a huge thing because these are often people that are quite young and haven't had children yet or haven't completed their family yet. And it's such a key part of what a lot of people want out of life. And it is an area that there's a lot of public goodwill and support for the idea of coverage. So if people are listening, if you go to Resolve, which we've talked about a lot, they have a whole website on their IVF for Vets campaign and trying to continue to push for making coverage permanent.
in my clinic, there's a lot of military down here in my satellite. This is just anecdotal, but I think there's been research backing this up too, that there is a higher rate of sperm abnormalities and other like direct issues on the gametes, on eggs and sperm. But I think that's ongoing in the research field. It'll be interesting to see what comes out with that. But certainly it is an area that these vets need care for sure.
And there are female veterans too. We don't want to talk only about the male side.
Something what Ruby said actually was done a study like this in Italy about teenagers and the sperm quality. And they saw some very abnormal results. So this is why it's considered a bit the environmental playing an important role in sperm quality. So here we arrive to everything, what it's endocrine disruptors and so on, but that it's not very known for this moment.
Yeah, and I think they're kind of questioning it. Is it's something in the military environment, something that they're exposed to, or what that's causing these sperm abnormalities? But yeah, I think the research is ongoing. It's very interesting.
It's dyspareunia, so it's pain during sexual intercourse, which it's more frequent. So this is, and low libido. So really, from my experience, I don't have something else which is coming up.
Do you often find people who have both? Because often if you're having dyspareunia, if intercourse is painful, usually you're going to end up having a low libido, even if you didn't start off that way. I mean, no one wants to keep doing something that's causing discomfort.
Yeah, you became avoidant. Yeah.
We've covered lots of different areas, and I think this is a fascinating conversation. It's an area that Anna and I are very interested in. So thank you so much for coming on to talk with us today. It was very enjoyable, and hopefully our listeners got some good information.
Just a taste of what's involved in sexual well-being, which I'm going to steal as a phrase now.
Yes, that's our new terminology. Thank you so much.
I thank you, because it was really nice to be able to speak so openly about so many areas. And I just hope that all the audience everybody will find something which can a bit give a thought. I mean, maybe even those who are a bit reticent with the sexual script still to work on it, they will find something which they can change or be more open.
Open the conversation. Maybe it'll spark somebody to see. I think here we call them sexual psychologists.
Yeah, sexual therapists.
Or sexual therapists.
Thank you so much for your time. Listen to our short stack. We've talked a lot on sort of the erectile dysfunction, more male side. We're going to delve a little bit more into some of the more common issues on the other side in our short stack. Thanks for joining us for this week's episode of the Whole Pineapple Podcast. We hope it was helpful.
If you know someone who could benefit from hearing the podcast, we hope you'll share it with them.
And don't forget to subscribe, rate, and review The Whole Pineapple on your favorite podcast app. Every rating and review makes us easier to find.
This podcast is sponsored by Seattle Reproductive Medicine and is produced by Audiotocracy Podcast Production. We'll see you next time. Have a delicious week.